Recording in progress.
Okay, welcome everybody to the Good Hormone Health webinar on June 22nd, 2025, entitled Role of Reverse T3 in Treating Hypothyroidism. That's going to highlight my new publication in a journal called PLS1. It's a fairly prestigious journal. Thank you everybody for joining today. The outline of today's talk is, the first topic is how reverse T3 is made. Is reverse T3 important? Why is this PLS1 paper important? What did it show? What are normal reverse T3 values? Who should get reverse T3 levels measured? How do hormones affect reverse T3 levels? And how can you lower reverse T3? So the thyroid gland is in the middle of the neck, right below the thyroid and cricoid cartilage. It has two lobes and is a butterfly-shaped gland. And I treat many patients with hypothyroidism, and there's various options for hypothyroidism treatment. And this is important to understand the paper. Most endocrinologists use levothyroxine alone. The brands are levothyroxine, which is generic, Synthroid, Levoxyl, Tyrosine, and Unithroid, and among others. There's gel capsules called Tyrosine, generic Tyrosine, and Thyroid. There's liothyronine, which is T3, which is Cytomel. There's a T4, T3 combination. There's desiccated thyroid. There's a brand called Athesa, which was available, I think is no longer available. There's Armor, Nature Throid. There was a brand called WP Thyroid, but it's no longer available. And in Canada, there's a brand called Urfa. These are often called natural desiccated thyroid or desiccated thyroid extract, DTE. You could be on combinations of desiccated thyroid and levothyroxine or desiccated thyroid and liothyronine. The proper treatment for hypothyroidism needs to be individualized. You don't have just one blood pressure medicine. You don't have just one thyroid medicine. And multiple studies have shown a poor quality of life among about 15 to 20% of patients on levothyroxine replacement alone, which I'll get into. In general, desiccated thyroid I use a lot of, and it's coming back. It was quite popular before the 1950s. And then synthetic thyroid medicines like Synthroid became popular, but desiccated thyroid is coming back. And many patients on desiccated thyroid, they may have a slightly high free T3, a low free T4, a low TSH. It has a little bit higher T3 to T4 ratio than humans. One of the main brands is called Armor. It's made by AbbVie and distributed by Allergen. There was a brand called WP Thyroid that was quite good, but WP Thyroid and its cousin Nature Throid, made by RLC Labs, have been on back order for about 5 years and unlikely to return. The brand I use the most is called MP Thyroid. It has more fillers than WP Thyroid, but still pretty good. And MP Thyroid was recalled in 2020, but not recently. And MP Thyroid is a great choice, as well as Armor. Some, but not all studies have shown a benefit of T4, T3 combinations over T3 alone. A large study in Italy, published in the journal PLS1, my article was published, found that patients without a thyroid given levothyroxine replacement, 15% of them had a low serum free T3 level, but normal TSH levels. This suggests that certain patients have different set points for secreting the pituitary hormone TSH, and some patients need the T4, T3 combination to achieve normal free T3 and free T4 levels. So what's the problem? About 15 to 20% of the population on levothyroxine monotherapy, means they just get T4. They have a normal TSH, but they have hypothyroid symptoms, including fatigue and poor quality of life. And this has been several articles have been written about this. And these are the vocal minority of patients who are not doing well on levothyroxine and would benefit from seeing a specialist like myself who can give them various combinations and try to figure out the best combination for treatment for them. So the question is levothyroxine plus liothyronine the correct answer? Is desiccated thyroid the correct answer? And is this hormone measurement called reverse T3 part of the answer? There's been 7 peer-reviewed articles, some of them in good, from my colleague, Dr. Wang in Bethesda, Maryland, and some not so good. But they all show that desiccated thyroid extract, TTE, was preferred over levothyroxine, and some articles showed that it was preferred over levothyroxine plus liothyronine. There was no study showing that levothyroxine was better than desiccated thyroid. The side effects, including feeling hyperthyroid, were minimal, and basically patients feel better on desiccated thyroid than levothyroxine, as described in this Medscape article. So it's important to understand the chemistry of the T4 and T3 and reverse T3, and it's shown in the picture there. The T4 can be metabolized by either deionase 1 or 2 to do the 5' deiodination, or the deionase 3, but the 2 works a little bit to do the 5 deiodination. So what does this mean? It means basically the T4 can get converted to T3 or reverse T3. This has been known for many years, and this is done primarily by peripheral tissues by type 1 deiodinase or by type 3 deiodinase to give the reverse T3. Type 2 deiodinase in the pituitary also converts T4 to T3 and is regulated a little bit differently from type 1 deiodinase. So I think the important point from this slide is that the thyroid can make both T4 from T4, the parent compound, the pro compound, can make either T3 or reverse T3. Reverse T3 is a biologically inactive form of T3 that may, although I don't think this is 100% sure, I think most people agree with this, block T3 from binding to the thyroid hormone receptor. Many years ago, probably in the 60s or so, endocrinologists realized that in severe illness, type 3 deiodinase increases, and the reverse T3 is often high, and the T3 is often low. Endocrinologists termed this sick thyroid syndrome and noted that it was common in many types of chronic illnesses, especially in patients hospitalized in intensive care units. It was usually recommended that these patients not be treated with thyroid hormone. In most cases, the elevated reverse T3 resolved when the patient's health returned. So again, this assay for reverse T3 was done widely many years ago, but mostly in sort of sicker patients in the hospital. However, more recently, doctors that used to be called alternative doctors, now they're called functional medicine doctors, have made a big issue about reverse T3. And I think in a sense they're right. And I think learning about them and reading about them, especially Dr. Ken Holtorf in Torrance, Los Angeles, made a case that the reverse T3 is important and that reverse T3 is detrimental, can block the T3 from binding to the thyroid hormone receptor. They also stated, probably correctly, reverse T3 can go in various conditions, including systemic illness, stress, inflammation, chronic pain, dieting, weight gain, and depression. And these studies often found that these diseases are correlated, although there's very little literature on this, with high reverse T3, but did not necessarily show that reverse T3 plays a significant role in their disease, or that reverse T3 is really important to get it down, or that the reverse T3 is truly detrimental. And these functional medicine doctors rely extremely on reverse T3 to treat patients that may have no other laboratory findings of hypothyroidism and often give them T3 only preparations to try to lower their reverse T3. And as far as I know, there was no publications on whether this is effective. And I've seen several patients that had a slightly elevated reverse T3. They put them on T3 alone to lower it. Most of the time it wasn't successful. Some of the time the reverse T3 sort of returns to normal on its own or with improving diet and exercising and things like that. And again, without publication, they use a ratio of high reverse T3 to T3 as an indication to treat these patients. And I did not particularly look at this ratio. I really looked at the absolute values of the reverse T3. And according to this website here, the factors that regulate whether T4 goes to T3 or reverse T3 include nutrients, iron, iodine, tyrosine, zinc, selenium, vitamin E, B12, B3, B6, C, and D. All play a role, and things that inhibit the production of thyroid hormone include stress, infection, trauma, radiation, fluoride, toxins, autoimmune disease such as celiac disease. And then factors that increase, and these are just make in general the production of hormones. And iodine is important, but iron is a very important cofactor. And factors that increase the conversion of T4 to reverse T3, what you don't want to have would be stress, trauma, low-calorie diet, inflammation, toxins, infections, liver and kidney disease, and certain medications. Factors that increase the conversion of T4 to T3 include selenium and zinc. So those are good. And factors that improve the cellular sensitivity to thyroid hormone include means that the thyroid hormone will work better at the cell, include vitamin A, exercise, and zinc. Mainstream endocrinologists and reverse T3, until my paper came out, have been very skeptical of the role of reverse T3. This article published in Frontiers in Endocrinology entitled Can Reverse T3 Assay Be Employed to Guide T4 versus T4 T3 Therapy in Hypothyroidism? The middle author, Dr. Wartofsky, is famous. The senior author, Ken Berman, is famous. The first author I'm not that familiar with, but I think she published a lot also. Their conclusion is reverse T3 is physiologically relevant to thyroid economy. However, its clinical use as a biochemical parameter of thyroid function is very limited. Currently, no evidence supports the use of reverse T3 to monitor levothyroxine therapy, either given alone or in combination with liothyronine. So they feel it's not worthwhile measuring reverse T3. And another article from the mainstream endocrinologist says, trust your endocrinologist report and recommendations on ordering of reverse T3 testing. This was published in the American Association of Clinical Scientists. And they concluded the diagnostic utility of reverse T3 for this indication is questionable, and testing of reverse T3 is not recommended by any professional practice guidelines. So me and my one of my medical students, one of my students, um, um, Julius Wilson, Dr. Thong Hong in Bethesda, Martin Lee, my statistician, another one of my students, Mayan Epstein, and myself gathered our data together. We looked at it for about 11 years, from 2010 to 2021. It took us a long time to sort of tabulate and publish it, but we did get accepted to publish in a journal called PLS1, published just recently, volume 20, edition 6. You can look at this link here if you want the copy, or it's also on my website. PLS1 is a peer-reviewed journal published by the Public Library of Science, and the article is available on goodhormonehealth.com. What we did is we measured reverse T3 in 976 patients. So it was a lot of patients who came to see me from 2010 to 2021 on my website, goodhormonehealth.com, with potential thyroid problems. And most of these really had signs and symptoms of hypothyroidism, and a good portion you'll see on upcoming slides were treated with different thyroid preparations. And I used the upper limit of normal for reverse T3 at either Quest or LabCorp, which is 24. I didn't calculate any type of ratios, and most importantly, we did get IRB approval from Charles Drew University, which was needed for the publication. So the patients were on a mixture of medicines. Of the 976 patients, 376 were on no thyroid medicine, 139 were on levothyroxine alone, 23 were on liothyronine or T3 alone, 83 were on T4 plus T3, 226 were on desiccated thyroid extract, DTE, 138 were on DTE plus levothyroxine, 15 were on DTE plus liothyronine, and 7 were on DTE plus levothyroxine plus liothyronine. And again, this is what they came when they saw me the first time. This was the initial visit. We got the reverse T3. And this shows the average values, the mean values of the different hormones. So the mean reverse T3 was 16. The standard deviation was 6.6. 976 patients had these blood tests done. The free T3, the mean was 3.2. Their standard deviation was 1.0. And this was 452 had it done. Free T3, the mean was 1.2. Standard deviation was 0.3. And 455 patients had this done. TSH, the mean was 2.3. Standard deviation was 4.3. And the number of patients was 513. So a little bit more than about half the patients we were able to get all their values at the same visit. But we got the reverse T3 of everybody. And this shows the graph of a whisker and box plot of the reverse T3 levels in these different groups of patients. And you can see that red line in the middle is the 24. And it's important to really look at the ratio here. So patients, none are in the blue, 31 of 345 had a high reverse T3. In the desiccated thyroid alone, 8 of 226 did. In the desiccated thyroid plus T3, 0 did. You can see that the ones on the T3 usually did better. In the orange, 24 of 138 had an elevated value. That's the desiccated thyroid plus T4. In the blue, 2 of 7 patients had an elevated value. That's the desiccated plus T4 plus T3. In the green is T3 alone. That's the lowest level. Only 3 of 23 had an elevated reverse T3 of that one. The T4 alone had the highest percentage, 29 of 139, had an elevated value of reverse T3 if they're on T4 alone. And T3 plus T4, 10 of the 83 had values. So the importance of this graph shows that the T3 really had the highest level. It's a little hard to tell with the medians, but the T3 went up. The T4 group had the highest level of reverse T3s. And this just shows the reverse T3 in patients on levothyroxine alone. 18.4 was the value. Patients not on T4 treatment was 15.2, and this was highly significant with a p-value of less than 0.00001. The percentage of patients with a reverse T3 if they're on T4 alone was 17.7%, and this is the T4 plus if they're T4 plus desiccated thyroid. The groups not on levothyroxine alone, 42 of 609, so 6.9%. So about half or a third of the patients that weren't on T3 had a high reverse T3. The p-value was extremely significant here. We then looked at correlations. This is called a Pearson correlation, and this measures how much the free T3 leads to the reverse T3. And you can see the free T4 and reverse T3s are very highly correlated. So if a patient had a high free T4, they very likely had a high reverse T3. If they had a high free T3, they were a little bit more likely to have a reverse T3, but not nearly as high. And we did the logarithm of the TSH, and the logarithm of TSH was correlated, modestly. So if they had a lower TSH, they usually had a higher reverse T3. So in terms of my overall results, the number of patients with reverse T3 levels above the normal range varies significantly with the type of thyroid hormone replacement. Overall, 11% of the patients had an elevated reverse T3 value, 107. The highest value of the reverse T3, 21%, was in patients taking T4 alone. And only 9% of the patients not on thyroid medicine alone had an elevated reverse T3. In contrast, only 4% of the patients taking desiccated thyroid had high reverse T3 levels, compared to 12% of patients on T3, T4 combination and 17% on desiccated thyroid T4 combination. Patients on all types of T4 treatment had higher levels than those not on T4 and a higher percentage of reverse T3 above the cutoff of 24. And the linear regression analysis showed that the reverse T3 levels strongly correlated with free T4 levels and more weakly with free T3 and inversely with log of TSH. We did look at the TPO antibody also. TPO antibody is a marker for Hashimoto's, and the levels did not vary whether they had with TPO status, except for the patients in a subgroup taking desiccated thyroid hormone. In this group, interestingly, none of the patients with the circulating TPO antibody had elevated reverse T3, while 7% of the patients without these antibodies had an elevated reverse T3 level. This was statistically significant, but I'm not sure this is real. This might be an aberration, but it does suggest potentially that TPO antibodies are beneficial for less reverse T3 elevation. I did not look at whether a high reverse T3 was correlated with hypothyroidism symptoms, but we plan to do this using the thyroid symptom questionnaire. And I have patients with a high reverse T3 and they're doing well, and those with a low reverse T3 are not. But I think this is quite intriguing. It seems like in general, the patients on T4 did have a high reverse T3. The results show that patients on T4 alone, often considered a standard therapy for treating hypothyroidism. And this is from our press release that's also on my website. The press release pointed out that these patients had the highest level of reverse T3, a biologic being an active hormone that can accumulate when the body fails to convert T4 into the active T3. In contrast, patients using T3 containing treatments such as desiccated thyroid extract had significantly lower reverse T3 levels, suggesting that standard therapies may not be optimal for all patients. My university, Charles University, continues to champion research that serves underserved populations and addresses longstanding gaps in health equity. The study underscores the value of re-examining medical norms in light of new data and patient experiences. The high patient prevalence of patients treated with thyroid preparations other than levothyroxine reflects the heterogeneity of providers as well as dissatisfaction with conventional treatment among this group of patients. So many patients seek out different doctors if they're dissatisfied with levothyroxine. And we found that the proportion of patients with above normal reverse T3 values varied specifically depending on the thyroid medicine they were taking. The proportion was highest in patients taking levothyroxine, but lower in patients taking desiccated thyroid or levothyroxine. Groups that took preparation containing desiccated thyroid or levothyroxine with T4 had a larger proportion of patients with above normal reverse T3 and groups that took without the LT4. So as I said before, the T4 treatment led to higher reverse T3 values. Our reverts are consistent with previous findings that in short-term settings, LT4 can raise reverse T3 levels and LT3 can lower reverse T3 levels. All these need to be verified in larger prospective studies that we plan to do. The strengths of our study include a large number of subjects taking different types of thyroid preparations, similar to what many patients are taking in real world settings. Another strength is the measurement of reverse T3 levels with an accurate mass spec methodology. Previously, people thought that the reverse T3 assay wasn't that good, but since it's done by Quest or LabCorp, it's quite good. The limitation of study included a potential bias. Subjects more inclined to take T4, T3, and desiccated T4 plus T3 and desiccated thyroid extract compared to that's seen in a typical endocrinology clinic. However, our findings of the highest reverse T3 levels in those on T4 alone, which favor higher reverse T3 levels in the endocrinology clinic, in which most patients are on LT4 alone. So potentially the bias sort of made our findings even more impressive as we had patients that were on other types of hormones that might have a lower reverse T3. Other limitations include the retrospective nature of the study. We went back and examined it, not prospective. We didn't have a measurement of quality of life. We didn't actually compare fatigue versus the levels which we will in the future. And we're not sure that the reverse T3 causes the fatigue or causes the quality of life symptoms, although it's suggestive that it does. And this should be addressed in future prospective studies. Our conclusion is that measuring reverse T3 may be helpful in some patients, especially those on thyroid treatments that contain T4. Reverse T3 is less likely to be helpful in those not on thyroid medications, as most patients not on thyroid medicines at a normal value. Patients that have an elevated reverse T3 on thyroid treatment, either T4 alone or T4 plus desiccated thyroid, they benefit from decreasing or stopping the amount of levothyroxine given and increasing the amount of levothyroxine or giving desiccated thyroid. Future directions include future studies are needed to understand the implications of the elevated reverse T3 in patients both on and off thyroid hormone replacement, and whether its measurement will be useful in clinical practice to guide thyroid hormone replacement. Randomized control studies are needed to determine if treatment with desiccated thyroid extract or levothyroxine in patients with elevated reverse T3 levels both lower the reverse T3 and improve measures of fatigue and quality of life. And additional studies are needed to determine which factors raise reverse T3 and if correcting them improves hypothyroid symptoms. Overall, our study will open up new avenues of thyroid disease research that could lead to improvement in clinical outcomes in patients with hypothyroidism. The area of reverse T3 is clearly an interesting area, and there is a clear division between endocrinologists who do not measure at all and functional doctors who measure almost everybody and may treat several people on it and may not need it. This test can be helpful in certain patients, but some discretion is needed to be used in who gets thyroid medicine, especially for the rest of your life, and who doesn't. So what are the normal reverse T3 values? We use the normal range of the lab, less than 24 nanograms per deciliter. And I would say you might even target it down to 20, especially if somebody's having hypothyroid symptoms, if you can. Who should get their reverse T3 levels measured? Patients on thyroid hormone replacement with symptoms of persistent hypothyroidism, such as fatigue. How do thyroid hormones affect reverse T3 levels? Levothyroxine usually raises it, and last thyroid or desiccated thyroid can often lower it. After you lower your reverse T3, increase the levothyroxine or desiccated thyroid, reduce your stress, lose weight, cleaner. And I think it's really important if you're having trouble with your endocrinologist and they don't want to measure this to come see me. I think I have expertise as I published really the first article in this area in several years. And maybe this will go on the radar of conventional endocrinology. We'll start measuring it. Functional medicine doctors often don't have the overall endocrine training to prescribe properly treat hypothyroidism patients. They often use too much, they use reverse T3 to the extreme. And I think they certainly lack my research and academic expertise, but there's many excellent functional medicine doctors as well. So this will be posted on my website soon. It'll be on YouTube. It'll be on Facebook. There's a Facebook link. We have a podcast channel. I also did a recent webinar, a webinar on your brain on diabetes. That's going to be on my website, also my podcast site. It's on Spotify, Apple Podcasts, iHeartRadio, Podcasts Index, and Amazon Music. A special thanks to Tiffany, my social media expert, and you can email us or call my website for more questions. Okay. We will take questions. Let me go into that here. We only have 13 patients. How many patients did you have on Facebook, Sophie? Sophie, how are you doing? Does anybody have any questions?
Thank you, Dr. Friedman.
Thanks. You
We
changed your
have,
name.
yes. We have about 20 people in and out on Facebook, but I do have a question here.
Okay.
James asks, when you say it's commonly mistreated, are you referring to when primary just prescribes Levo for everyone?
I think hypothyroidism is mistreated in general. Many patients do fine on levothyroxine, and I work in my county job at Martin Luther King Outpatient Center, and 95% of my patients are on levothyroxine, and they're doing quite well, most of them. It's the patients that are seeing me that aren't doing so well that are having the problems. And they often have hypothyroid symptoms. They don't measure the reverse E3. Most primary doctors, or probably even some conventional endocrinologists, just measure TSH. They don't look at the free T4, free T3, which are often important. So that's what I'm saying, how they're often mistreated by most endocrinologists and primary care doctors.
Thank you. If anyone has questions on Zoom, please type them in the chat box.
And any questions on Facebook?
Yes. Janet asks if reverse T3 is high on labs and someone is taking Armour thyroid plus tyrosine, does it make sense to reduce tyrosine?
Yes, it does. And actually, Janet was one of the first people that got me inspired to do this study. She asked me at least 10 years ago or so, is reverse T3 support? And I said, I don't think so, but let me start looking at it more carefully. So I think if somebody has a high reverse T3 and they're on the levothyroxine or Synthroid or Unithroid, they should cut down or stop that medicine and maybe replace it with desiccated thyroid or T3.
Linda asks, how much zinc and selenium do you need to convert T4 to T3?
So most people have enough zinc. I usually don't add that, but people can be deficient in selenium. And I think a good amount of selenium to take is 200 micrograms. It does help reduce your TPO antibody and does help with T4 to T3 conversion. You can get it on Amazon quite readily and and you can at Trader Joe's. And I usually don't measure the selenium levels. I just encourage people to take some selenium. It usually doesn't hurt too much, and it's a good supplement to add.
Um, Any other questions? Anybody?
I guess they all got it.
Yes.
Okay. So do another one coming up probably next month. And I'm
Mhm.
also again going to post my one of the diabetes and mental condition issues.
Betsy did ask, was reverse T3 measured in correlation to patient's weight? For example, were higher T3 reverse T3 levels correlated with higher weight?
That's a good question, Betsy. I did not do that. Potentially could do that. Okay. We'll see you guys next time.
Okay, thank you so much, Dr. Friedman. Please visit Good Hormone Health to see Dr. Friedman and make an appointment with him.